Okay, good afternoon, everybody. A warm welcome to Healthwatch Hackney information exchange on eating disorders in adults. My name is Sara Morosinotto. I am the Entry Review Manager here at Healthwatch Hackney. For those of you who do not know Healthwatch, we are the health and social care watchdog. So our job is to use the feedback that we receive from our patients to basically suggest improvements in how people can access and use the health and social care services. We also provide information about the services that you can access, and hence this meeting today, and how these can be accessed so that, our patients can make an informed choice around their rights and health and social care decisions. And finally, we act as a bridge between the patients and the health and social care providers. So I'm now going to introduce you to our speakers today. We've got Dr. Brian Srinan, who is the clinical lead for this London eating disorder. Hi, Brian.
Hi, everybody.
Lovely to have you today. And then we have Sarah Mann with us as well. Hi, Sarah. Welcome. Sarah is the People Participation Lead for Eating Disorder Service. Hi, Sarah. Thank you for coming
Hi,
today.
thank you for having us.
And I think it's over to you, Sarah, now, while I share my screen with the presentation.
Great. So, hi everyone. Thank you for coming along, or for watching afterwards, if that's the case. We are here today to do a bit of an introduction to eating disorders and disordered eating. We are going to talk about, a little bit about what that means, what they are, a few facts about them, how they function often, like what's going on psychologically, and then a bit about what can maybe help for people who have eating disorders. And as part of that, the support that we offer in East London Adult Eating Disorder Service. So we're based at East London NHS Foundation Trust. As Sarah mentioned, I'm the people participation lead in the service. What that means is that it's my job to make sure that people's real lived experience is constantly informing the way that we run the service, to make sure that it's done based on, I guess, not just facts from books. So as part of that, I use my own lived experience of having had an eating disorder, but most importantly, I support other people with lived experience, patients we've had in our service, to get involved in doing the same via various projects. One of the ways we do that is through these education and training sessions. So we thought, when we start with the first section, what is disordered eating? We thought we'd start that with sharing the experience of someone who has been through our service and is part of this lived experience work. So we will hear from her first.
Thank you, Sophia, for being with us today.
Yeah, thank you for inviting me.
Do you want to tell me a little bit about yourself?
Yeah, I'm 19 and I'm going to go to uni this year to study sociology and criminology. And I'm here to speak about my experience with an eating disorder. And to be honest, my message is like I want to portray something that might help like people in this journey and in this path to show them that it is okay to have this um, like problem and that it will get better and it always does get better.
How did it all start, Sophia?
Well, to be honest, I was trying to lose weight. I used to be very overweight and I was trying to lose weight, but then it became an obsession for me to lose weight constantly and constantly. And well, in the mirror, I started to see something that wasn't true because I was becoming a normal weight, but I still felt like I was still the overweight person that I used to be. And so I went to the doctor and I asked for a dietitian, which was probably the wrong thing to ask for because he then referred me to the eating disorder mental health service because he saw that something was well, clearly not okay with me. And so yeah, that's how I then got diagnosed with an eating disorder.
When did you realize that there was something that was quite not right?
I think when they told me that I had an eating disorder, that's when it kind of like hit me. Because I remember when I was diagnosed, I felt like I couldn't really see anything anymore. I didn't really understand what was going on. I thought I was okay, but the professionals said something else, that obviously I had an eating disorder. But until that time, I thought that it was okay to be losing weight the way I was, be consistent, like constantly obsessed with exercise, with my diet and stuff like that. But clearly that wasn't the right way to lose weight.
Did you recognize any of the signs and symptoms?
I feel like no. I think even before I got diagnosed, I didn't really know that much about eating disorders, which I think is a problem in itself. I feel like it should be taught more, maybe in schools or something like that, because I feel like people don't recognize the symptoms themselves that much. Because oftentimes it's people that tell them that there is something wrong. Because I remember my mum kind of told me that this was becoming a problem, but I didn't really see it myself.
What made you reach out for help?
I think after I got diagnosed, I think that's when I kind of started to realize that there was something wrong, and I didn't want there to be something wrong with me because it was starting to eat up like my entire life and affect me a lot. And I feel like I had a lot more things going on, so I didn't really need that extra like stress in my life.
And what was recovery like?
I feel like recovery is never a straight line, and I think that's the like most important message that I want to get across to people today. That it's never a straight line. It's okay to have dips, and it's okay to not always like have a target as well. It's okay to not be all right all the time. I thought I was getting better and it was going to stay that way, but then all of a sudden I was getting worse again. So I think the most important thing to recognize is that yes, it will get better, but it's not always going to be straight away.
What is next for you, Sophia?
Well, I'm looking forward to doing more of these projects with people because it means a lot to me to be able to help other people the way that I would have wanted to be helped as well. I think it's different what the statistics say and the facts about eating disorders to what someone actually goes through. So I think it is important to get across that message of like a personal message that might help other people.
Thank you. And so, what is your message to the people who are listening to us today?
I think the most important one is that it's okay to have an eating disorder. It's not like it doesn't make you strange, it doesn't make you abnormal. It's okay. Like things like this happen to people. And it doesn't mean that you can't get better. Like always, there's always a chance to get better and you will get better.
Thank you. Thank you for taking the time to talk to us, Sophia.
Thank you.
Great. Thank you for playing that, Sarah. If we could just go to the next slide. Thank you. So we thought we'd just start by playing Sophia's experience there because I think that story really powerfully pulls out some of the points about understanding what disordered eating and an eating disorder is, which I'm kind of just going to touch on the basics of those now. So you might have noticed that on the kind of intro slide, we talked about understanding disordered eating, and you might be wondering like, what's disordered eating? What's an eating disorder? Is it the same thing? And the reason that we often use that term is that we find it quite helpful to understand these issues on a spectrum of disordered eating. So when we're talking about disordered eating, we are talking primarily about a psychological component of mental distress regarding someone's relationship to food. And that's really the first point I wanted to highlight, because I think when a lot of people think of an eating disorder, they think of what someone looks like, they think of their weight. And really the most important thing that I want to pull out, and that I think Sophia demonstrated really powerfully there, is that it's the mental element of someone's relationship to food that defines this. So at one end of the spectrum, you've got what we might think of as a healthy relationship with food. So where the choices someone makes around what they eat are primarily driven by things like hunger, availability, preference, any particular allergies or anything like that. There's not really any guilt or shame around food. They're able to be flexible, respond to hunger and fullness cues, but also give themselves permission to eat for reasons other than hunger, because, you know, food plays a really big role in social connection and things like that as well. And then in the middle, we've got what we call disordered eating. Some of you might recognize quite a lot of this as quite normalized in society, to be honest. Things like food choices being influenced by a desire to maintain a certain weight or body type, or driven by other anxieties. A higher sense of guilt around food, kind of starting to see some more rigid rules, rituals, routines, that kind of good, bad mindset, assigning moral value to what you eat. And really a kind of increasing preoccupation and distress and anxiety. And then at kind of the right end of the spectrum, the right hand end there, you've got kind of what would meet clinical diagnosis for an eating disorder. So that really is defined by like the extent to which this kind of guilt and shame and distress around food is really dominating someone's life. So one thing I picked out that Sophia said there was this kind of like obsession that was really like eating up her entire life. And that's very much kind of what an eating disorder does feel like, regardless of the presentation. It's, you know, if you drew it out as a pie chart of what your brain's taken up of, like the vast majority of that is going to be the relationship to food. So yeah, we kind of find it helpful to start by conceptualizing it like that, because I think it helps with some of the questions later about what can help and what can stop things developing. Eating disorder diagnoses are like, they're not perfect. They can often exclude a lot of people from them. So thinking of it in terms of disordered eating as well, I think is a more helpful way of making sure that everyone gets the help that they need and deserve, and making sure that, like, if, you know, the earlier on this spectrum we can kind of intervene and support someone, like, the easier it's going to be, and more likely it's going to be for someone to recover, we hope. So if we could just go on to the next slide. And then these are just a few facts that I will quickly go through that really just summarize the points I've just made, and which are essentially here trying to challenge some of the really commonly held stereotypes about eating disorders. The main message, is they're a complex mental illness. I think we could hear from Sophia there, like how, you know, there was a real message of hope there, but also just how difficult they can be to recover from. That it's not superficial, it's not a fad, it's not, you know, a diet gone wrong or something that's just like gonna go away if it's not addressed. Like, they are serious and they have to be taken seriously. And yeah, there are mental distress, and this may or may not have physical consequences, such as weight loss, weight gain. A lot of people's weight might stay the same. As you can see there, like, only about 6 to 8% of people diagnosed with an eating disorder are classed as clinically underweight. Anorexia is actually the least common eating disorder diagnosis. And yeah, really just want to get across the message that eating disorders don't discriminate. Anyone can get them, any age, gender, ethnic background, sexuality, and actually experiences of marginalization are like a risk factor for, you know, developing mental distress, such as an eating disorder as well. And I'll just pass over to Brian to speak a little bit about some of the diagnostic specifics.
Thanks, Sarah. Hi, everybody. So I'm not going to kind of take up too much of people's time, because all of these things on this slide you can Google freely. There's decent information out there about these things. But I suppose just to highlight some of the main kind of eating disorders that are prevalent and that we see in our services across East London Foundation Trust. So I think people very often, like Sarah alluded to, when people think about an eating disorder, very often people think about somebody who's, you know, suffering with anorexia nervosa. So things around kind of very much about a restriction about food and drink, having to overcompensate, generally having very, very low weight compared to their heights as well. And with anorexia, I guess there's a fear, and I think it's a common across eating disorders, a fear of weight gain, and often kind of a sense of being unhappy with kind of body shape in general. Second was bulimia, and people, I think this is quite a well-known one as well. So this is kind of cycles of binging and purging. So kind of binging on foods and that being uncontrollable generally. So people consuming a huge amount of food in a short period of time, followed by periods of compensation. And that generally tends to be purging. So it could be about kind of using laxatives. It could be about self-induced vomiting, etc. Or it could be another overcompensating factor, such as excessive exercise. And these people who suffer with bulimia are most typically in the what's classified as a normal BMI, and we'll potentially touch on that as we go along. I think Sarah will cover it in a little bit. So binge eating disorder then is the next, and I think this is often something that's overlooked and is not seen in society. So this is people who kind of exist in larger bodies generally. Their BMI, their body mass index tends to be on the kind of overweight end of the spectrum. And it's classified generally as people eating large amounts of food over a very short period of time. But the difference between bulimia, maybe, and binge eating disorder is the compensatory behaviors aren't as prevalent. Now they usually are as prevalent in terms of, sorry, they usually are prevalent in terms of people tend to restrict because of guilt and shame about having a binge, and that just it builds up hunger, and it gets to the point where people's blood sugar is extremely low, and then that forces people to binge again. So you've got that cycle that's being maintained. ARFID is another one that's often overlooked, but we're seeing more and more people with this presentation in the service as well. So that's avoid and restrictive food intake disorder. So this is about, it's not necessarily about somebody, how they see themselves physically and about a fear of weight gain or shape and weight concerns, but it's more to do with textures and tastes with regards to eating. So it's not like picky eating, only eating certain things. It's a very visceral sense of disgust that people can have around certain tastes or textures or smells. And that can really impact somebody's relationship with food and therefore their weight and shape as well, cause clinical harm. Orthorexia is kind of a new term. It's not an official diagnostic category, but that's when people get very fixated on clean eating, wanting pure foods, etc., have very rigid food rules around what food is good, what food is bad, and what food that they'll allow themselves eat. So the obsession becomes quite unhealthy and can lead to people being malnourished in the long run. And OSFED is other specified feeding and eating disorders, a really catchy term. But I guess this is when people don't obviously meet diagnostic criteria, formal diagnostic criteria for anorexia or bulimia or binge eating disorders, say, they might miss out on the thresholds, or it might be a mixture of the disorders. So this is thinking about like having a maybe a trans-diagnostic formulation of the difficulties. So I'll pop onto the next slide. As I said, all of these things are Googleable. So the next bit is about the prevalence of eating disorders, and Sarah touched on this a moment ago. So this pie chart is generally where we see presentations with eating disorders. As you can see, anorexia and ARFID only are kind of 8% and 5% respectively of eating disorder presentations. Binge eating disorder is almost 25%, it's 22% there. Bulimia is 19%, and OSFED then is 46%. It's really common for eating disorders not to say fixed, but for people to migrate across eating disorders over time. So very often when you speak to somebody and they've had an eating disorder for a long time, they will have had a number of these difficulties. And it's the core of the issue, I guess, that we're trying to support them with in treatment. So next slide. And this is just a little bit about how eating disorders can differ maybe from one population to another. This isn't a huge study that was done, but this is data that was collected by Eric Uccini, who was the clinical lead, or used to be the clinical lead in the CAMS, or Child and Adolescent Eating Disorder Service in East London. So the blue columns are people from a Caucasian background. The kind of orangey color is from an Asian background, and the gray is from a Black background. And what you tend to see as a rule of thumb is that people from Caucasian and Asian backgrounds tend to veer towards more the restricting end of the spectrum. So anorexia presentations, say, whereas people from Black backgrounds tend to kind of present with more of a bulimia, that binge purge presentation again. Now, there's lots of caveats with this data as well in terms of how society sees people, whether there's institutional bias, racism, etc., and what's seen and not seen between different groups of people as well, and what's picked up. So I suppose that's just a caveat to front load on this data. This is a very, like, let's kind of fly through this. Sarah, will I hand over to you for this one?
Sure, yeah, or maybe we could pick some out together.
Yeah.
But I guess we kind of included this on here more like, we can share the slides as well afterwards, but if people would find it a useful resource to refer back to. But just in terms, like, before we go into some of the more like nuance of what's going on underneath with an eating disorder, it can be helpful just to think about some of the more like common concrete signs and symptoms as well. Like, they're very much not an exhaustive list, but it can be helpful to think of them as like physical, behavioral, and psychological, and whether that's to kind of recognize those like in yourself, or like in a loved one, or someone that you are maybe concerned about and wondering if it's something they might be struggling with. Yeah, I think one thing that I would say is that, it'd be useful to kind of maybe hear briefly, Brian, like what you think could be picked out from here as a couple of kind of key ones. But for me, I would say the psychological ones are the most important, not least because I think a lot of the behavioral stuff, you might see from that column on the right there, can be quite secretive, can be quite easy to hide, and can be actually quite easy to hide from yourself as well. Physically as well, like a lot of this stuff is not necessarily visible. Like, as we've said, a lot of people don't lose weight with an eating disorder, or don't lose an amount of weight that might be like, noticeable to other people. So yeah, that's what I would kind of say there as well. Yeah, I don't know, Brian, from a clinical perspective, if there's any that you wanted to pick out.
I think it's helpful, Sarah, like you're doing, is to think about it more broadly as well, rather than kind of the nuance. Like you're saying that if this was purely a physical difficulty that people had, it would be quite easy to think about, okay, what behavioral changes could you make to support somebody with these physical difficulties? But generally, what tends to underpin eating disorders is this psychological difficulties, and that drives the behavior, and that has an impact on the person's physicality then, therefore. So like we've kind of touched on a little bit in terms of the guilt or shame that people might experience around eating, about, food preferences, good foods, bad foods, etc., that people can categorize. The preoccupation, so the influence from society that we're getting all the time about bodies should look a certain way. It's being reinforced in social media, etc., and has been for decades, but maybe more prevalent now. And that feeding the preoccupation with weight, food, calories, etc., and that having an impact then on people's behaviors and the physical sensations as well, and physicality that people have as well. And this is all reinforcing as well. So the more people, I suppose, are preoccupied with their weight and shape, the more they will have rituals around food. There might be calorie counting, concealing, etc., and that then will reinforce the physicality. And what people tend to find, and this is a broad generalization, but that there's a sense of diminishing returns with eating disorders as well. At the start, people can be praised for losing weight, etc. There's a lot of reinforcement externally, and people get a sense of, perhaps there's lots of different functions of an eating disorder that we'll touch on, sense of control, sense of achievement, etc. But over time, there's a diminishing return with that. And like Sophia said, that in the end, it started causing stress, having a massive impact on our life, overtaking everything, having to think about food all the time as well. And that's when it kind of tips into the diminishing returns, and it not being something that people want to maybe change, but that can take a bit of time for people to get to that point.
Mm-hmm.
So perhaps we'll go on to the next slide.
Yeah, thanks, Brian.
Please.
I can maybe expand on that a little bit more now. So as we're trying to hammer home the point that the kind of psychological stuff is really like the root of everything, that might leave some people wondering, like, well, why, why are people developing this, psychological relationship with food where there's so much distress? Like, why is that happening? I guess the first thing I would say is, like, mental illness doesn't always have a logic. But secondly, as well, that actually eating disorders for a lot of people can serve a function where, they might not be aware that it's serving a function or not. But a really helpful way for some people to think about this and to kind of break down what might be going on there is, in this way we framed it here, is that the eating disorder is an answer to a certain question. So, if the eating disorder is the answer, what is the question? So some people, for example, might use certain behaviours as a form of self-punishment. So that might be restricting the amount of food they eat because they feel like they don't deserve to eat, or they only deserve to eat at certain times, or only in certain settings, or things like that. But that can also show up with behaviours like binging and purging as well. So feeling like you deserve to make yourself feel physically uncomfortable from the amount that you're eating and things like that. So then a question that you might ask from that is, well, why do you feel that you deserve punishment? Why are you feeling like, you need to perform or measure up, or, are not worth enough as you are, and not deserving of, what is essentially, what is a basic human need for adequate nourishment. Another really common one you might have heard is control. I do think the control one can sometimes be oversimplified. It's the main one that people might be aware of, and there are some people where actually they're having an eating disorder feels incredibly out of control. So that might not resonate with them. Having said that, it does resonate with a lot of people. I think, a question to be asked there is looking at, what might feel chaotic or disordered or overwhelming in their life. If someone's experiencing kind of certain events, if someone is neurodivergent and the world to them feels very confusing, the eating disorder can often feel like this almost internally created world where you make the rules and you understand things. A couple of others on there are things like escape and self-soothing. And Brian mentioned a moment ago, can't remember, he said it in a professional way that I don't remember, but basically about the kind of all those different columns we had being sort of reinforcing and then getting into a cycle. So it might be that, someone might have started something almost sometimes consciously as a means of control, but very quickly it can kind of spiral. And I think we heard kind of a little bit of a sense of that from Sophia, that it can spiral and then the rules can almost kind of create a logic of their own, and before you know it, like they've taken control, those rules, and you're not actually seeking to self-punish or control or escape anything anymore, but this disorder and this set of rules has taken over and you are compelled to follow them, and it can really often feel like an addiction. And I think that's what's so difficult to break down, because the person experiencing it might not really understand what's going on either. And if we could just go on to the next one. So going, I guess, expanding a little bit on that sort of mindset there, is just wanted to show you this visual in the sense of addressing ambivalence, because I think a lot of people that are either experiencing an eating disorder or trying to support someone who is might think, well, I want to get this person to see that I think they need help, but they're not seeing it. Like, how do I get through to them, and this, that, and the other? And there can really often seem to be this ambivalence about change. And I think that can often be seen as, do I want to change or not? And I think a helpful alternative way of seeing it is actually the ambivalence is, do I deserve care or not? Do I deserve to recover or not? Like, do I deserve to be taken seriously? So, nothing we say here is ever going to apply to everyone. So if anyone is watching this and thinking, I feel like something's wrong, but I don't relate to this, like, if something's wrong. So please, take whatever from this is useful and leave the rest. But what a lot of people experience is getting to that point of diminishing returns, like Brian mentioned, getting to that point where the distress caused by the eating disorder seems, is affecting them more, taking over their life more than any kind of perceived benefits. that were shown on the diagram just before. So there will inevitably at some point be a part of the person that is thinking, you know, I really want to break this cycle. Like, I don't want to live this like this anymore. Like, please help me. On the other side, there is an often much louder part of their brain, which is saying, I'm not sick enough to deserve help. I'm a fraud. So that can be driven by, often with an eating disorder, there's a desire to kind of almost do it to the best of the ability, feel that you need to be an absolute rock bottom before you deserve help, because the eating disorder is always telling you, like, you're not sick enough, like, no one will believe you, I don't believe you, you're a fraud, this, that, and the other. And unfortunately, traditionally, a lot of the way that the diagnostic criteria has been created and communicated and the way that services have been set up, like, does reinforce this. And a lot of stereotypes that exist in society around eating disorders, like, obviously people with eating disorders have internalized those as well. So essentially, if you're not maybe at a certain weight or don't have a certain frequency of behaviors, all that external stuff, that's really like fuel to the fire of this part of you that's telling you that you're a fraud. So what I would say is, like, a really powerful way, whether as the external person doing it for someone else, or the person themselves offering to themselves, is this validation and permission to change. So I know that eating disorders can often seem like this kind of alien, confusing thing, but essentially it's about distress. And if you're able to offer any kind of, or attempt to offer any kind of sense of connection and support to anyone else experiencing mental distress, then you are very much capable of doing that with someone with an eating disorder as well. And I think the most powerful thing that someone without specialist expertise can do is, you know, speak to that left-hand side, speak to that part that wants to break the cycle, that desperately wants that other part to pipe down so they can crack on with it. Like, show that you believe them, say that you believe them, give them permission to identify as sick enough, you know, regardless of, you know, what overall narratives are, regardless of what their weight is, of what they look like, anything like that. Anything you can do to speak to that left-hand side is a really powerful thing. And hopefully, as the person kind of starts to hopefully kind of get out of that cycle as well, with time, they will start to be able to offer that validation to themselves. So yeah, just a bit of a summary of the points that I've gone through there in terms of like what can help, and like how to maybe ask someone about an eating disorder and how to talk about it, because I know it is still like quite a taboo topic. Yeah, the main thing I think I really want to pick out is, like, don't be afraid to ask and don't be afraid to talk about it. Like, it's okay that you don't have all the answers, and just showing that you're trying to understand and showing that you're taking someone seriously and that you understand it's about the psychological stuff, can be really powerful. Eating disorders really thrive on like secrecy and loneliness, so anything that can challenge that can be really helpful as well. I think avoiding making assumptions as well. I think a lot of us will have assumptions based on common stereotypes. So, you know, not assuming if someone tells you they're struggling with an eating disorder, not just assuming straight away that they never eat or anything like that. You know, expressing that might make someone feel like, you know, they're a fraud because they do eat and things like that. So kind of just going back to that chart I just showed as well, and that mindset, anything you can do that will speak to the left-hand side. I think patience is really important too, for the individual as well, but that is such a hard lesson to learn. But recognizing, like Sophia said, that recovery is not a straight line, and it's not, you know, someone isn't choosing to find it really hard to recover from an eating disorder. Like, it just is hard. It's possible, it's very possible, but it is hard. And also, I guess one thing I just wanted to pick out as well is an awareness of how someone's environment might be impacting them. So we've kind of mentioned it earlier in the session, but society in general, really, I think, encourage, you know, weight loss is praised. A certain amount of moralizing around food is quite normalized. I think commenting, I think one thing that people don't realize is that even someone else commenting on their own, you know, their own body or their own eating habits in a negative way could impact on someone with an eating disorder. And you might think, well, I'm not saying about them, I'm saying it about me. But for someone with an eating disorder, you instantly, in your mind, you internalize, you're like, right, well, this person places importance on that thing, so they're going to judge that in me. So I think that's something that, both in terms of maintaining an environment that might be less likely to lead someone to be vulnerable to developing an eating disorder, but also for creating an environment where recovery is more possible, and just removing that as a barrier is really important as well. And then if we could just go on to the next slide. We are going to talk a little bit about like what professional support is available locally in Hackney. And as part of that, I just wanted to highlight a resource that we have in the service on this theme of the importance of, I guess, validation and challenging stereotypes, and how we really feel that is really important for kind of tackling eating disorders and like giving people the chance of recovery they deserve. As a group of people with lived experience, we recently created this guide, this booklet, which we have on our website. There's a hyperlink on a PowerPoint, so that can be maybe circulated afterwards as well. But yeah, basically in this guide, it's different people sharing their experiences of, coming from different backgrounds and experiencing eating disorders that might not necessarily fit the stereotype. The vast majority of people don't, and showing that, actually, just because you don't fit a stereotype doesn't mean that your distress isn't valid. I think that reading it could be helpful for kind of understanding the kind of insecurities and uncertainties of maybe your loved one, if you think that they're struggling as well. And really just showing as well that there's all sorts of different types of recovery, people from different cultures, from different backgrounds, different there's all sorts of things that can influence what a recovery might look like for you and what a meaningful life might look like for you. And it might not necessarily always look exactly like what a specific, traditional model of recovery looks like. And yeah, basically, we just wanted it to be a resource to help people to validate themselves as well. Because again, I think that validation of someone's distress and the fact that you deserve to live without that distress, whatever clinical threshold it is or isn't hitting, I think that's one of the most powerful things in being able to even start to contemplate recovery. And I'll pass over to Brian to talk a little bit more about the professional support that's available in the service.
Thanks, Errol. So just very briefly to say, we have a new community eating disorder service in East London, which covers Hackney. We started taking referrals in August 22, so we've been open for almost 2 years, 18 months to 2 years at this stage. You can self-refer, so if anybody who is struggling with an eating disorder can go on our website and self-refer. We accept professional referrals as well. But we also have colleagues in other services who are specialist training with regards to how to support people with eating disorders. So in Hackney, the IAPT service, Talk Change a City in Hackney, their staff have been trained in terms of how to support people with eating disorders and have a nice National Institute of Clinical Excellence there, a model of cognitive behaviour therapy that's recommended by NICE as a first port of call for supporting people with eating disorders. We've got our community team, like I said, and also we have inpatient support for those who unfortunately need that. We partner with Barnet Enfield and Haringey and have support there in terms of inpatient support. But I think if any people have kind of want to reach out, we have our website, we've got our contact details on that, and we'd be more than happy to talk to people, either professionals or residents, in terms of their if they have struggles with eating and food related difficulties too. So I think that's it for us. I think it's just maybe to think about if people have any questions.
Thank you, Brian. I'm going to stop sharing my screen now. There we go. Okay, and we started the Q&A session. So I did receive some questions from people as they registered. So if it's okay with you, before I have a look at the chat, we start with those questions in the registration form. So the first one is, what does role medication play in recovering?
Yeah, so I might take that one, Sarah, perhaps. So generally treatment for mental health difficulties there are recommended by a panel of experts, and they're under the umbrella of the National Institute for Clinical Excellence. That's NICE. You can Google any psychological disorder, and NICE will, or most psychological disorders, vast majority, and NICE will have on their website recommendations as to what the different treatment types should be. So with regards to medication, NICE recommends that eating disorders shouldn't be treated with medication only. And usually the medication that's recommended is for comorbidities. So if somebody had an eating disorder and underlying depression or anxiety-related difficulties, etc., those difficulties will be managed by medication, with the eating disorder not necessarily so. Also, it's quite, I'm not an expert, I'm a psychologist by background, so I'm not a psychiatrist or a medical doctor, but it's the doctors and medics need to be quite careful in terms of the dosage that people are getting because of the side effects of eating disorders as well. So I think it's always very closely monitored when people have an eating disorder and also need medication too. But like I said, like NICE recommends that it's not a standalone treatment, that psychological therapy is usually the first treatment of choice for people with eating disorders.
Thank you, Brian. We do have another question, in fact, two questions that I'm going to kind of join together. How can we develop a healthy relationship with food before I develop an eating disorder? And the second one is kind of along the same theme of preventing. Is there a way to prevent eating disorders?
It's a big question, but an important one, definitely. I mean, I think in terms of, you know, so the first one, it was about developing a healthy relationship with food, right? I think the important thing, and I don't want this to sound kind of defeatist at all, but I think the important first thing is to recognize that, like, that's not an easy thing to do, and I actually think it's quite a radical thing to do in like our society. But it is definitely like possible. I wanted to flag that because I guess like I'd like people to have, like, if it's something people are struggling to do, just like to have self-compassion as well, because I just think we don't live in a culture where that's, you know, necessarily always encouraged. And then related to that, it's going to be different to different people. So I perhaps will speak from I will speak just from personal experience, then maybe Brian can add anything he wants to. For me, I think actually educating myself about things like diet culture and weight stigma and the kind of historical and social roots of that was really, really, really helpful for me. For me, it was very helpful in recovery because it gave me, I guess, knowledge to recognize where certain comments or certain attitudes were coming from, and that helped me to find them, I guess, over time, like less triggering and easy to like build boundaries around. And I guess I would think if I had had that knowledge before I developed an eating disorder, you know, it's hard for me to say, oh, I definitely wouldn't have developed one, because I think a lot of people are just like predisposed to it. But I think it would have made me, you know, I could have created an environment for myself where I was less vulnerable to it, definitely. So yeah, that would probably be my initial answer to that. Brian, I don't know if you had anything to add.
I think it's a really good point, Sarah. I think we could talk about this for days and days, if not longer. The things that come up for me are, yeah, definitely accepting how society portrays or portrays a certain image that's an ideal in terms of people's bodies, both for women and men. And that's very difficult to get away from. It's so I think being mindful of what people follow on social media is really important, and being mindful in terms of what the aspirations are as well, in terms of how people relate to their bodies. I think a really nice way to think about our bodies is what they can do for us rather than what they look like. So there's a nice metaphor that people, or delineation that people make in terms of think about your body as an instrument or an ornament. So think about think it more like an instrument in terms of what it can do for you, and how it's almost incredible that we can stand on 2 feet, walk around the place and swim and jump and do all the other things and hug and everything like that, as opposed to it being an ornament standing on a mantelpiece that should be observed by others and judged in terms of its aesthetics. The other thing is, I suppose, just thinking about the food rules that people have and the comments that people make and the praise that people give in terms of for people's weight and shape. It's so common that people will comment on people's weight loss as a really good thing, and there could be actually quite difficult things behind it. One of which could be an eating disorder, the other could be quite severe illnesses that are going on, but also how, categorizing things in terms of good foods, bad foods, I'm being bad because I'm having this, etc., how that can really perpetuate the societal narratives that are out there. But I think the one of the big things as well is having that self-compassion and thinking, knowing when you're struggling, and that's okay to struggle, and thinking about then how where the best places to get support for that is. But I think, yeah, we're swimming against a big swell, as Sarah said, in terms of what's out there in social media more generally, and the media. So I think but I think we can all take responsibility for our own part that we play in that.
Yeah,
Thank you.
and I think just to add to that, definitely agree with all of that. And also, if you can't stand on 2 feet because you're disabled, or you can't run and jump because you've got chronic fatigue syndrome or whatever, you still deserve to look after yourself in the way that you can, and nourishing yourself adequately is part of that as well. I think for a lot of disabled people, intersections with eating disorders have a different layer of nuance and complication as well, and that can often be left out of the conversation. So yeah, I think the reason I keep banging home the point about validation, validating others and also validating yourself, is that I think it's so easy to see narratives around health or mental health, eating disorders, things like that, and feel excluded from it. And if you're feeling distressed, so you deserve to validate that for yourself. And it's really difficult to do if you're feeling like others aren't doing that for you, even if it's inadvertent. But I'm telling you, you do definitely deserve to. And that's not going to fix everything, but I think it is an essential component for growing that recovery as well.
Thank you, Sarah. I've got one more question, then I'll come to you, Seth. Thank you for waiting patiently. So someone said, English is not my first language. Do you offer an interpreting service?
Yeah, we do. Yeah, we offer interpreting services, and also some of our therapists speak other languages as well. So yeah, we can either get an interpreter or hopefully maybe pay for that person in-house either.
Brilliant. Thank you. Nice and easy. Seth, do you want to ask your question?
Yeah, thank you. Really, really interesting, insightful guide. So do appreciate it. I actually work with young people. Obviously aware this is sort of about the adult service, but quite a few of my clients are transitioning into adulthood. And I was just wondering your thoughts on, obviously that's a very challenging time, I mean, just across their lives, but particularly for someone who's previously, so the people I work with have previously been treated for eating disorders, some of them. There's a lot of anxiety about moving into adult service. And I was just reflecting as well, whilst you were talking about how some of these relationships, well, our relationship with food and eating comes from childhood and adolescence, and the social environment, from my experience working with young people, is hugely pressurized, and yeah, I think food and eating is a big part of that. But yeah, I'm quite a bit concerned about some of my clients who are moving into that adulthood and potentially moving into adult services. So I was wondering if you had any thoughts on working with that sort of younger adult cohort that are coming into the adult service. Nothing particularly specific, but just any sort of thoughts or tips or ideas that you might have.
So yeah, it's a really good question, Seth. And I think yeah, our relationship with food is just touching on something that you said. It's, if you think about fundamental soothing, I guess that's like most people are fed, milk fed or breastfed, etc. And that's our first experience of having that nurture as well. So like there's really deep rooted relationships with food that often are kind of overlooked, I think. So and that kind of goes into the function of why people might restrict or not feel like that they're worthy of certain things, etc. So, but that's going off on a slight tangent. I think a couple of years ago, I would have been really pessimistic in terms of people transitioning from CAM services to adult services. But in the last couple of years, since starting the community team, we have support now for people in adulthood across the spectrum of eating disorders. So I'm much more hopeful in terms of that. Our team alone has expanded from, we started off with, I think we're up to 22 or 23 staff now. So none of those were there before across East London, but now there are brand new 22 staff supporting people with eating disorders from 18 plus. And I think if people are kind of approaching 18, etc., and they're not being seen by CAM services, we have a good relationship with our CAM services where they can do some prep work perhaps, and people then can transition into the adult services. Then pre-18, we can do all the bureaucracy that needs to be done in terms of paperwork and thinking about how we can support the person and then get going once they turn 18, if not a little bit before. So I think the best thing to do would be just to reach out. We've got our email address on our website. There's always somebody manning that Monday to Friday, 9 to 5, excluding kind of bank holidays. But we will get back to people then quickly. So if you have any questions, it's not only for referrals, say, but if there's any questions that people want to ask, we're more than happy to communicate with people via that way. The other thing to say is that once a month we have a consultation with St. Anne's Eating Disorders as well as slot on a Thursday. It's the third Thursday of the month. It's open to anybody working with people who are supporting people, residents in East London, but more specifically around eating disorders. And perhaps, Sarah, I can send that to you, the meeting link. It's open access. People can join when they want. So if there are any particular questions that you want to ask or get a bit of ad hoc supervision, people are more than welcome to that space as well.
Thank you, Brian. And I think this gives me a really good opportunity to also mention that we have in the pipeline an information exchange about eating disorders in children, and we will touch the transition between children's service and adult service as well, because we know that can be a bit of a pain point. Thank you. Before I come to you, Catherine, if that's okay, I wanted to read a question that we have in the chat. So my problem is that I have not enjoyed eating since I was a child. I often skip meals, but I love sugary food. I also don't like hot cooked food. I keep saying that I just eat to stay alive. However, my body is in normal shape. Do I fit in any specific category?
That's a really interesting one, I think. I guess I'd be thinking about, it comes down to the stress. So I think categories are useful for thinking about like broad generalizations, thinking about like what works generally for different struggles. But I think the most fundamental thing for me is it causing you distress? Is it upsetting you on a regular basis? Is it impacting your life, your ability to function, say? And if the answer to that is yes, then I think it's worth maybe looking up the service, maybe doing a self-referral to talk more about it. If it's no, I guess it's just thinking about like why is it coming up for you? Why is this important to you as well? I think it's once people are looking after themselves and caring for themselves, and if it's not causing distress, then I think people should be able to live how they want to live. But I think the most important thing is the distress that it's causing, and if it is, then we can definitely have a chat. What do you think, Sarah?
Yeah, I would agree with that. I don't think I have anything to add there.
Brilliant. Thank you. And over to you, Catherine.
Yeah, I thought really, really interesting, presentation and information. And, I was really interested to hear how only, you said 6 to 8% of people are underweight. And I think, we have heard about people sometimes not being accepted into programs because they're not thin enough, they're not underweight enough, which I hope doesn't happen now. But yeah, my sort of question was more about people who may be overeating and binging and things. I know we've had an information exchange once about obesity and weight, and so I don't, and people get told about there's, you know, exercise programs and healthy eating programs, and possibly they're not really addressing some of the sort of real issues that people are having with food. And so do you think that people are getting properly referred? Well, can they be, you know, if they are struggling with overeating, is that something that they can be is that an appropriate referral to yourselves? And do you think that lots of people who do have that sort of issue, are they getting those sort of referrals? Yeah.
Well, I start first, Sarah. You can jump in. So yeah, thanks, Catherine. I think it's a really important point, and we didn't linger on some of the really important stuff around how there's such a weight bias in society, and there's such kind of fat phobia and shaming, fat shaming, etc. that happens. I think so many people just don't get the support that they need. I think even, you know, colleagues in other services see the problem as a physical difficulty, or somebody, you know, they don't kind of know what to eat, or they know, you know, how to exercise, etc. And, you know, kind of broad brushstrokes like that. And that really is failing people. So I think we are trying to work more with the kind of weight management services that are commissioned normally across the boroughs. But I think the most important thing is if somebody has an eating disorder and they're in a weight management program, it can be really feel quite shameful that, you know, why aren't they making the changes, etc. And others around them might be. I think so. The most important thing, I think, is to tackle that, tackle their relationship with food first, and then think about how they can, you know, improve that relationship and go on then to let their body do what it's going to do over time. And I think so our service definitely from the outset, if people do come in larger bodies, our aim isn't to make people lose weight or anything like that. The aim really is to think about the person's relationship with food and try and change that, and everything else after that will usually fall into place. And I think there's sometimes a bit of time, and there's a time and a place for weight management services, in terms of there is that sense of being in a group and doing something together can be quite rewarding and quite motivating, etc. So I think if it comes in at the right point, I think there's huge benefit to those. But I think them on their own, I think, and especially if somebody has an underlying eating disorder, can be more unhelpful than helpful. That's just my personal opinion on that. Well, and professional opinion as well. What about you, Sarah?
Yeah, I'm aware of the time, so I'll try and keep it brief, but I agree with all of that. And I guess the points I have to add is, yeah, that thing about the mental relationship being like the most important thing as to whether like an eating disorder service is appropriate for them. And then on the flip side, actually, like some people just naturally exist in like a larger body, and like we can't assume from looking at someone that they might be struggling with binge eating disorder, for example. Like that might be what their body is like. And yeah, I would say, yeah, I totally agree, Catherine, that some of those kind of weight management programs won't be meeting someone's actual need because that mental stuff going on, but that also I think could be like very harmful if someone's in that place as well, because you can't cure or seek recovery from an eating disorder whilst actively trying to lose weight. Like you just can't, because it just reinforces all those mechanisms that make up the eating disorder. So yeah, and I guess my final point would be that kind of, you know, related to Brian's point about fat phobia and weight stigma, which kind of underpins really, and this isn't what Brian said, this is what I'm saying, underpins like, you know, public health and like approach to it and a lot of things there. And actually health can mean different things to different people. And I as someone that has recovered from an eating disorder, I like managing, like paying too much attention to nutrition and like the amount of my food in a way that might be healthy to someone else. Actually, for me, that's just a big risk factor. That's not what health looks like for me. Maybe that will be different in the future, depending on how my health changes or whatever. But actually, like, you know, maybe for some people, like existing in a body that is larger than the medical system wants them to be, but where they don't live with a devastating mental illness, that might be what health looks like for them. So just an awareness that is different for different people.
Thank you. Seth, do you have another question, or is your hand still up from earlier?
Sorry, I didn't unraise it. I'll
That's
do that.
okay. I just wanted to make sure. That's
Yeah,
fine.
thank you. I appreciate it.
Are there any other questions? It doesn't look like it. Okay, we've got to the end of our time. So I really wanted to thank you, Dr. Brian Srinan and Sarah Mann, for being with us today. As I said at the start, I will share the recording and the slides early next week to all of you who attended today and to all those who registered, so that you can find the recording and all other information exchange events on Healthwatch YouTube channel. I hope you have a lovely evening, everyone, and enjoy the rest of your day. Thank you.
Thanks, everyone.
Thanks very much.
Thank you.
Thank you.
Bye.
Bye.